Vision and refraction are vital to any ophthalmic examination, especially in children. But estimating vision and refraction in young children is challenging. Seeing a child in the clinic for a vision and refraction exam puts both the ophthalmologist and the child in a fix. In this video, we bring you the right methods of easy vision assessment and simple tips and tricks for a seamless vision assessment in children. Here we present vision testing with OKN drum in infants. Optokinetic nystagmus is elicited by moving a large piece of paper covered with black and white square patterns in front of the child's face at a distance of 40 cm. The number of saccades in response to left side stimulation is compared with that of right side stimulation. Optokinetic nystagmus test is normal when the response to left and right side stimulation is symmetrical, whereas an asymmetrical response will indicate an abnormal result. This test can be done for children of up to 3 to 6 months of corrected age. In slightly older children or toddlers, forced preferential looking tests like teller acuity cards or tag cards may be used. Two stimuli are shown: a grating composed of black and white stripes and a grey screen of equal space with an average luminance. An observer, unaware of the location of the pattern stimuli, is positioned behind a peephole located centrally between the grating and the homogeneous field. The observer monitors the direction of the child's eyes and head during stimulus presentation. Acuity is estimated by determining the smallest striped width to which the infant will show differential fixation for the grating as opposed to the homogeneous field. Here is a tip. The observer must look through the peephole. Holding the card in front of the child with the observer looking above the card might distract the child as well as induce bias in the observer. Do not provide audio clues to the child by tapping on the card, as this might also mask or confuse the response. Tag cards are usually flipped and held in horizontal orientation only. Here is another tip. In cases of horizontal nystagmus, inability to generate neck or eye movements as in cerebral palsy or oculomotor apraxias, tag cards can be assessed in vertical orientation. The child will look up or down in response, and visual acuity can be reliably assessed. The advantage of tag is that visual acuity can be checked at different distances. LIA paddles. LIA paddles are another form of resolution acuity testing which will measure acuity as cycles per minute. They contain a control paddle and a test paddle with gratings. This is typically tested at 30 cm and can be oriented laterally and vertically to assess visual acuity. In special children, when there is no response to either paddle, slight movement of the paddles may initiate a response. Dynamic motion on the stimulus will initiate a visual response in special children. Matching cards. Recognition visual acuity can be assessed by matching cards. Children with special needs, developmental delay, amblyopia or crowding phenomenon may not respond and may get confused when presented with the entire vision chart with multiple lines and optotypes. This is due to crowding phenomenon, where they have difficulty in processing multiple visual stimuli. In such cases, allowing them to match single optotypes at distance will give the precise visual acuity and potential of the eye. Refraction. Retinoscopy is an art by itself, and for children this art becomes stressful and tedious. Children refuse to wear trial frames as they are very heavy. 4-opters are scary. Free lens refraction is easy and children cooperate better. Retinoscopy can be performed by holding individual lenses in front of the child's eye. The child does not feel threatened by large frames in this process. In addition, using full aperture lenses can help in better retinoscopy because children may not fix well and may turn their heads while examining. Full aperture lenses as opposed to mini aperture lenses can give a wider field and easier access to retinoscopy in young children. Children with nystagmus, eccentric fixation and large head postures can also benefit from full aperture trial lenses. Dynamic retinoscopy. Accommodation assessment is done by MEM retinoscopy, wherein there is a card with letters attached to the retinoscope. This is a dynamic retinoscopy that is done with the patient reading a near print and accommodation is assessed. In children who do not read at near, dynamic retinoscopy can be done by assessing retinoscopy at distance fixation and at near fixation. A myopic shift will be noted at near. To encourage fixation to an accommodative target at near, a toy or sticker with fine details can be used on the retinoscope. This ensures good shift of fixation from distance to near, inducing accommodation which can then be measured. Over refraction. Children with high refractive errors, high plus or minus, who come with glasses for review need not be put through trial frames and loose lenses again. Refraction can be done over their existing spectacles to assess for change in refractive error. Here is a child with aphakia and nystagmus, unable to maintain central steady fixation. Over refraction with her own spectacle is hassle-free than a trial frame and mini aperture lens. The child also cooperates much better. Following these techniques will enable quicker and a more efficient clinical examination, thereby making life all the more simpler.